I can. So I live and work in Galway, and that's a shot of the Galway clinic where I work from. And I'm currently the director of the Fertility Care Centres of Europe. It's a registered charity trying to make fertility care known in the medical world. And we have a bit of a job like LDN. It's little known what we do, and we believe it's highly effective, but LDN is part of what we do as well. So I'm well familiar with the whole LDN concept to get a little guy known in a big world. Our European website is fertilitycare.net, and I have a copy of this presentation put on at fertilitycare.it. So if people are rushing to take notes, and I'm skipping quickly, you'll get it all there at fertilitycare.it. We were 10 years in practice this month last year, and we had a big celebration party. And 500 out of the 800 children that had been born with the techniques that we use came to celebrate our party. It was a great event and attracted a bit of attention. And the techniques we use are called natural procreative technology, or NAPRO technology. And essentially we use a combination of the best medical and surgical techniques we can to facilitate conception through a normal active intercourse without recourse to in vitro or artificial insemination. And we find that nature can do a pretty good job if you make the conditions right in the first place. It was developed by a professor of obstetrics and gynecology from the United States in Omaha, Nebraska, Professor Tom Hilgers, in association with Creighton University. We've had 800 babies born in Ireland at our 10th anniversary. I was just looking at our figures since the start of January. We've had an additional 100 conceptions from January up to the present time. It's 100 and something at this stage. So thankfully our practice is going really well. Our average success rate is about 50% for infertility. We get between 20 to 30% success for couples with a history of failed repeated attempts at IVF, and we effectively treat recurrent miscarriages about 80% of the time. We've got one publication from our practice, the first 4 years of practice. These are the worst figures you'll ever hear about the work that we do, because it was before we were using LDN and a lot of other things, but at least we have one publication to introduce physicians to the work that we do. There's a textbook that contains a huge amount of information about what we do at naprotechnology.com. And essentially what we work with is a fertility care chart, and it's this that has allowed me to find out that naltrexone can do something for infertility. Because the chart keeps asking us questions and keeps challenging us to find new ways to solve the problem that we're presented with a couple who can't conceive. And we document what a normal chart should look like. We look at the bleeding pattern, the dry days, the mucus days, the day of ovulation, and we time blood tests around that. We perform ultrasound studies, surgical investigations, and when we put it all together, we get a picture of what a couple's fertility profile is like. And if it isn't looking right, then we try a whole range of different treatments, including naltrexone, to try and restore normality. Initially, it was developed as a system of family planning, and the question was asked, could the charts be telling us something more than simply where the window of fertility is? And it was recognized that women who suffered from infertility and miscarriages had very unique abnormal fertility care charting profiles. When it was evaluated further, a lot of the time it was related to low hormones. You get an abnormal looking chart, you check the hormones, you find that they're low, and that would be the problem. We could predict who was at risk of infertility, miscarriage, or abnormal pregnancy outcome, like premature delivery. Even before it happened, we could identify at-risk groups. And the treatment, when we applied treatment, the chart would tell us if our treatment was effective or not. So if you had an abnormal chart, you found the low hormones, you gave the hormone treatment, the chart would return to normal. Sometimes, though, it wasn't the hormones, and we found that in this case, we had to give antibiotics to restore a normal fertility care charting pattern. And this is where it starts to get interesting for the LDN group. Sometimes we found we had to go for immune-modifying strategies with a drug called Enbrel that I'm sure some of you know about. It's a cytokine inhibitor that's used in a whole range of immune-related abnormalities. This one is commonly used for rheumatoid arthritis, and sometimes you have to go for immune modification. These days, I use naltrexone as the immune modifier for our immune-related abnormalities. Naltrexone, interestingly, has been part of the NAPRO technology program since 1985, when Dr. Hilgers first developed this as a system. Basic research showed that it was related that endorphin deficiency was a problem with PMS, infertility, and miscarriage. This has been published I won't go through the publications in detail for you because I want to skip through it pretty quickly, but it's been published in the 1980s that low endorphins are related to these problems. There was a double-blind placebo-controlled study using naltrexone, and if you look at the dose, 25 milligrams twice a day to try and improve PMS, and not surprisingly from what we know now, you didn't get a great result from it. There was some improvement, but it didn't achieve statistical significance. The mechanism of action was, it was thought the endorphins are low, you give naltrexone, that'll boost endorphins and that'll improve all these problems. Initial results, because of the kind of doses of naltrexone that were being used, I believe, initial results weren't very convincing and naltrexone didn't appear to be very effective. We had additional problems that in the United States, before they give naltrexone treatment, they'd always measure endorphin levels, and if endorphin levels were proven to be low, then you get your naltrexone to try and stimulate endorphins to improve the fertility. We couldn't do the endorphin test, so I couldn't tell which patients should be getting endorphin stimulation. It was perceived as a less important treatment, so I didn't really prescribe it initially. My sister, Marianne, however, she's written a book on MS, Up the Creek with a Paddle, and she discovered naltrexone online, and she found this as a new treatment for her husband for her MS, went to Bernard Bahari in New York, and he put him on the naltrexone, and she was asking me, well, what do I think about it? And I said, well, it definitely won't do any harm, the recurring theme that we've been hearing from everybody. So I said, he's got nothing to lose by trying it. And it was interesting because I was familiar with the drug already as a fertility treatment. I said, that's odd, it's being used for MS as well. And so my brother-in-law Noel went on it, and ever since he started it, there's been no progression of his MS. But I just took that as an interesting aside, and then out of loyalty to Marianne, I went to a friend's presentation on naltrexone, Robert, in 2003, and I listened to him give a talk from a patient experience point of view, and I have to say I was blown away. It was clear on the evidence of one patient alone to me as a physician listening to it, this was not a placebo effect. The kind of benefits that we've heard explained from Joseph, what he's experienced, from Linda, and from anybody who's taken any of this naltrexone, what it does for their lives and changes them, it is not placebo effect. It's too dramatic and it's too profound. And I was super impressed with his presentation. I thought, this is fantastic for MS and now rheumatoid. And I was thinking, and he explained that it improves immune function through stimulating endorphin production. So my immediate thoughts were, is it like some kind of faith healing or magic or even worse again, placebo? But I thought it couldn't be any of these things. It's got to be more. So I was looking up at their website at that time, and I was discovering what we all know about the way naltrexone is used to treat these conditions, and the way that Bernard Bahari showed that the low dose of naltrexone gives a threefold increase in endorphin levels. So I thought maybe this is why our high dose naltrexone for infertility hasn't been working as well as we had hoped. But that penny didn't drop for a while. I'm a little slow. And my thinking was it's for autoimmune type of conditions, and that's primarily what it's for. But I made a plan, if I see anyone with an autoimmune condition, I'm going to give this a twirl and see what happens. For me, it was very obvious, why wouldn't any doctor try this? Low toxicity, inexpensive, it seems effective clinically, it's easy to take, you don't need specialized physician training, there's few ethical issues about it, and personally I would have anticipated widespread acceptance and use by the medical community in no time, and that's on the basis of listening to one patient at that time. But I was shocked. There was a huge resistance among physicians to even try it out. And I was baffled with this, and today it still baffles me to some degree. And the doctor resistance, some of it could be understood. Well, it's unlicensed for autoimmune disorders, as we've heard. It's an experimental treatment. It's not evidence-based. Doctors aren't covered by medical insurance, and it's too risky. But to be honest, when I looked at it, there's about 170 drugs in Ireland that are used outside of the product license. That's not something that's very new. So there's something different about naltrexone, because doctors prescribe unlicensed medications all the time. There's something different. That's an excuse. It's not a reality. So I'm disturbed by this. And I believe that it's a degree that it's not a thing that a clever doctor would prescribe. What would my peers think? I think that's a big thing among physicians not prescribing it. I go to continuing medical education talks, and a lot of the time it's an exercise in one doctor showing another of how up-to-date they are with the published journals or the peer-reviewed studies and what's good, and everybody's nodding in agreement. And I went to a talk on rheumatoid arthritis, and I was bursting to tell them about my clinical experience with low-dose naltrexone, but I knew that that wouldn't be clever and it wouldn't be accepted in that kind of a forum. And I know of a very good drug that I could tell these guys about, but I know it's just like, he's a GP and, he doesn't really know what he's talking about. He's not familiar with what's published and so on. Things are starting to change. Most people just don't want to stand out from the crowd. I'm less disturbed about that because the fertility treatment I do, by its nature, it stands out from everything else that's currently available, so it's part of what I do anyway. And the evidence, when you're looking at evidence-based medicine, the question we're supposed to ask about it is, what level of evidence is available to support a chosen treatment? Well, there is a theoretical evidence, there's clinical experience. I think you could put a 0 behind that for 4,000 plus MS patients that have been treated. And the publication in peer-reviewed journals, that's changed. We've seen some of the publications that are there. So the results have proven that it's safe. We know for sure from well-designed clinical studies this is definitively safe, as well as knowing it from clinical experience. The MS study, or the Crohn's disease study that showed the 66% remission and 89% improvement in the 17 patients from Professor Jill Smith, that pilot study, one really important point about that is 75% of those patients had tried and failed Enbrel. That's infliximab, excuse me, it was infliximab, a cytokine inhibitor, the top of the range, the $1,500 a month drug. 75% of these had failed with that drug before trying low-dose naltrexone. So the conclusion of that study was more study is needed. I know. If it wasn't so serious a thing, it is that laughable, only for it's so serious. I've got two problems with these studies, and one from my whole natural fertility point of view is that when I was speaking to Professor Jill Smith, she said that there was no improvement in mood for a lot of the patients in the study. And I'm baffled with that because I see, and I'm sure you experience it, how mood improves so much. And it's mandatory for all females of reproductive age to take contraceptive steroid birth control while they're on the low-dose naltrexone trial. And this is masking the effect of the mood improvement. I just point in the direction of Yasmin Survivors Forum. If you Google Yasmin Survivors Forum, you'll get some indication of what this can do to mood. And it's a real problem if you're trying to assess the clinical effect of how to improve mood. You've got to do something to remove it from the birth control scenario, so maybe you'll have to check it on men or women who aren't of reproductive age, or find some way around this other thing. But this other thing that I have a problem with is this idea that more study is needed. The conclusion should be everybody start prescribing LDN yesterday. I just don't understand what the problem is. There really isn't any, and there's no justifiable one. My sister, as part of the whole LDN community as well, she was so passionate about it. She wrote her book, and she's trying to get her book out there so other people can read of, well, how could I do something? How can I take a drug that my neurologist said is rubbish? How come it's not licensed? She goes through all the thinking that people go through with all of this to explain, here's why you need to take LDN. And most people who come to my practice, before I prescribe it for them, I am getting people coming purely for MS and autoimmune conditions from word of mouth. And the criteria I have for them is, did you look at the website, lowdosenaltrexone.org? Did you read the book? I usually put them to this one. I'll be recommending LDN Google and as well, because that's available for free online, so that's great. And then I say, try and get it from your own GP or your own specialist. And if all of these avenues fail, fine, then in conscience, how can I not give LDN to somebody who needs it when you're aware of the great clinical benefit that somebody can get from it? Now, I have a hugely busy practice. We've got 120 people on our waiting list. We've got about a 3 or 4 month waiting list at the moment. And LDN is going to make us even busier than we can hope to cope with the demand. So it's more important that other doctors start prescribing this, really. My early experience with it, I gave it to a personal friend of mine with early onset rheumatoid arthritis. Straight away, he had huge improvement. I gave it to an infertile patient with rheumatoid arthritis. She was advised you need methotrexate. If she goes on methotrexate, she can't get pregnant because of being on that particular drug, and more than anything, she wanted to be pregnant. I put her on the naltrexone with dramatic improvement, and another man who tried and failed methotrexate and was told he needed Enbrel he had a huge improvement with naltrexone as well. These were the first 3 people that I'd ever treated. To look at the infertile, I mentioned it to my local rheumatologist in the clinic where I work, and he said you can't justify efficacy of a new treatment with just 1 case. It was probably placebo. It's a risky experiment. If it doesn't work and joint damage occurs, you're potentially liable, and he wouldn't even recommend it. So there is a fear factor there as well. But having used it for so long and having listened to so many people using it, really that fear is unfounded. This first patient that I treated with a fertility issue, she had polycystic ovaries for 10 years. She previously had a successful pregnancy in our program, but it took us about 18 months to get there. And while she was trying to get pregnant the second time, she was diagnosed by her rheumatologist as having rheumatoid arthritis that were resistant to non-steroidals, and she was advised methotrexate, in which case she couldn't continue with her fertility treatment. So of course I said, try this LDN. Straight away, 80% improvement in her symptoms, absolutely no side effects, and 2 months later she's pregnant. At the time it didn't dawn on me that the naltrexone had something to do with her getting pregnant after 2 cycles, whereas it took us about 18 cycles before, so I told you I'm a little slow. But eventually I figured it out. Maybe I had some patient in desperation. Everything I tried from a hormonal point of view wasn't working. And I said, well, I don't know, but I've got an experimental drug. Maybe it might do something for your fertility. And I said, we could put you on. It might help your PMS, if nothing else, while we're waiting for your surgery. She goes on the treatment with the naltrexone, and she had severe intractable PMT as well as infertility. And we put her on the naltrexone, and she got a positive pregnancy test. Sadly, it ended in miscarriage. From a hormonal point of view, I wouldn't have been surprised because her hormones were in her boots. So, but we got somewhere that we never got before by adding naltrexone to her. Was naltrexone a failure? Well, it was a partial success because we got a positive test, but more than that, clinically, she had dramatic clinical improvement of severe intractable PMT that anything else I gave her didn't work. And she conceived after 4 months. Now, low estrogen levels are a big issue for us, and we treat that, and it's related to this whole story as well. She was found to have severe endometriosis as well, so we had to continue working on other things to hopefully try and get success for her. So very much there appears to be a common link between PMS, infertility, and miscarriage. These are endorphin levels from women with endometriosis. The normal fertile population, their endorphin levels are up here, and women with endometriosis, their endorphin levels are half of what the normal population should be. Professor Tom Hilders was big into measuring endorphin levels. For 4 years he hasn't been able to do it because the company that made the kit to allow him to measure the endorphin levels withdrew the kit. Wonder why they did that. 50% of women with with polycystic ovaries also have endometriosis. So if you've got a diagnosis of polycystic ovaries, there's a 50% chance you've also got endometriosis, and there seems to be an endorphin deficiency issue with that as well. So this whole question between polycystic ovaries, endometriosis, recurrent miscarriages, could it have something to do with endorphin deficiency or abnormal immune function as a result of these low endorphins? Could immunotherapy be one of the missing pieces from our jigsaw of fertility treatment? So our abnormal fertility charting profiles, could part of it be related to abnormal immune function? And the answer today is yes. We had a big headache because we were trying to figure, well, how are we going to treat these people? How do we figure out if we can't measure endorphin levels, how do I know who's going to benefit from naltrexone? Well, from clinical experience, we were able to determine what criteria would be likely to benefit. We used to say that LDN is experimental. I don't say that anymore. I've been using it too much for too long, and for me it's not experimental. For me it's a part of established clinical practice, and it's not experimental. Even though it is experimental in the broader medical community, for us it's an essential part of our fertility treatment for about 50% of patients who come our way. It's that big. We use a lot of it. These are the list of criteria we've come up with. We've got 8 criteria that give us clinical clues as to whether somebody has endorphin deficiency or not. Premenstrual. I'm going to take you through a little bit of a journey of discovery of what I used to do before LDN came along and the difference that LDN made by adding it to treatment. Hardly anybody talks about estradiol deficiency. Most people don't even measure it. We do, and we can identify it. We recognize it as a problem, we correct it, and we get better outcomes with it. Here's an interesting case of a lady who had 3 previous pregnancies. The first was a successful pregnancy. which she delivered at 33 weeks gestation. That's 7 weeks early. Baby was 5 pounds 5 ounces and had to spend 2 weeks in special care baby unit. Mum was, what do you see, she had hives or urticaria during pregnancy, and she developed severe cholestasis and itch with abnormal liver function tests. So it's like her immune system seemed to be attacking her liver during pregnancy, and she used to get these hives, and it was this whole reason is why she went premature as well. Her first pregnancy, despite the difficulty of it, she did carry it, but she lost the 2 babies after that. She came to me at the age of 33 in January 2003, and she had no investigations because there's nothing medically you can do unless you've had infertility for at least 1 year, or unless you've had 3 miscarriages. You're off the radar for infertility evaluation and treatment with her condition. So she doesn't fit the criteria for having a fertility problem, whereas for us she does. So she had no medical investigations before coming to us. We looked at her fertility chart. It was off the scales abnormal. I won't go into the details because obviously we're a bit pressed for time and we're not about fertility today. But she was ovulating very late, had a very short second half or luteal phase of her cycle, and hormones in her boots. And I was surprised she could even get pregnant with a chart like that. If we see a chart like this, we tell somebody, don't even try to get pregnant in the first place. You're high risk of things going wrong. Let's fix your chart before you get pregnant, and we're much more likely that you'll get pregnant and have a successful outcome. So we had a whole load of things wrong with her chart and atrocious hormones. We put her on hormonal treatment, and we restored a normal appearance to her chart. But her estrogen levels were resistant and not responding to everything I tried. Her hormone levels, in fact, went a bit above our target range, and we knew we were potentially near twin territory, and we got a positive test. And I was still worried for her because we didn't have the optimum preconception environment. Her estrogen was low, her bleeding pattern was abnormal, she was ovulating late, and her PMS was still a problem. This is my pre-LDN days, before I knew about it. We had a twin pregnancy. Due date was July of 2004. And I said, I think there's some immune factor working against you. Let's put you on a steroid, prednisolone, as an immune-modifying strategy to hopefully prevent these problems. I know this dose of prednisolone is safe during pregnancy, and a lot of physicians, certainly at that time, were recommending it to try and reduce the risk of miscarriage. So we put her on our hormonal treatment plus prednisolone as an immune-modifying strategy. She got nearly all of the problems again, but she went a week and a half later than she did the first time, and the babies only had to spend 1 week in special care baby unit instead of 2. So there was some improvement with the prednisolone, but it was nowhere near as good as what I had hoped it was going to be. And I kept asking the question, what did this? What's the problem? Now, I found out about LDN since then as my new immune-modifying strategy, and she came back in February of 2006 wanting to get pregnant again. This time she was developing premature menopause. Her ovaries were going into failure. And ultrasound showed a thin lining to her womb. She didn't have a period for 6 months, and she was getting premature ovarian failure, which is because of your immune system attacking your ovaries. So my question was, does premature ovarian failure start with low estrogen in the first place? And today I can say the vast majority of the time it does. So are we getting anti-ovarian or anti-estrogen antibodies prior to getting the elevated FSH and premature ovarian failure? Could her problems of the urticaria and the cholestasis have an autoimmune basis? Maybe she'll benefit from naltrexone. So I told her we could try this as an immune-modifying strategy and see if it works. So we put her in a load of treatment, and she had twins, bear in mind, the first time, and she was coming now and her ovaries were going to sleep. She was approaching the menopause, and she said, we love our twins, but we haven't come back to you for 3 years. There's a reason for that. The twins nearly killed us. Whatever happens, we don't want twins again. And I said, twins, don't worry, you're not going to have twins. Look, your hormones are in your boots. You'll be lucky if we even get 1 egg released out of your ovaries the way things are going. And her hormones were absolutely atrocious. So we put her on hormonal stimulation, and with the combination of the naltrexone, her ovaries went mad altogether, and her progesterone went up to nearly 400. Bear in mind, she had twins with progesterone of 120. And we didn't talk. She came into the room. She was mad. I was scared. And the husband was mad. And we're thinking, oh, God, what's going to happen? So we did our scan, and thanks be to God, only 1 of the eggs got picked up and fertilized. But I'm convinced we released at least 3 eggs. And God is good. And so this time I said, now, okay, we overcame that hurdle. There was a surprise. It really took off with naltrexone more than I'd anticipated. Let's keep it going during the pregnancy in addition to your hormonal treatment and see what happens. And this time she got no hives whatsoever. She had some morning sickness, so we reduced the naltrexone to 2 milligrams, which I'm sorry I did, but things still went pretty well. She'd no itch at all until 35 weeks. She used to get her itch at 29 weeks. We went 6 weeks later. I'm convinced if I kept her on it at the 3 milligrams, we wouldn't have got it at all. Her liver enzymes started to go off just a little bit at that stage, but she went to 38 weeks, had a 7-pound baby, much heavier than the other ones, and no special care baby unit at all. So this was a much, much healthier pregnancy, much, much better, not perfect. And in the future, what I would do for her is I'd very much look at her diet, and I'd be supplementing with vitamin D3 and omega-3 and keeping her in even higher doses, and we wouldn't even get a sniff of this problem. I'm convinced we'd have it licked. So that was the first one where we're just discovering the benefits of naltrexone for somebody, and also the safety during pregnancy. Many people have contacted me to say, I've got MS, I'm trying to get pregnant, can I take it during pregnancy? Absolutely yes. We've had over 50 babies that have, whose moms have been on naltrexone throughout their pregnancies, and those babies, if anything, are even healthier than the kids whose moms haven't been on the naltrexone. It is 100% safe. They are super healthy. The pregnancies are fantastic. They don't seem to get sick. They're good-tempered. They're good-humored, and the babies do fantastically well. Miscarriage, it's more than just the loss of eggs. It's quite devastating for anyone to go through the trauma of miscarriage, and this particular couple had been through it 6 times with no success. They came to a stage, she was age 33, and each time everything ended in miscarriage. Very commonly you have in a situation of unexplained recurrent miscarriages and you don't know why it's happening. We looked at her chart and we said, well, your chart doesn't look quite right. You know, we can do our hormonal and usual treatments with this. This is pre-LDN, and we found out, and I was saying, I think there's something immune here as well, in an intuitive sense. She had premenstrual syndrome, she had abnormal bleeding, low hormones. I put her on hormonal treatment. We restored a normal appearance to her chart with optimum hormones, gave her the all clear to try to conceive, and I decided, in addition to hormone treatment during the pregnancy, we'll put you on an immune modifying strategy with prednisolone as well, because intuitively, from her clinical picture, I figured there was an immune factor. We monitor hormones throughout the pregnancy, and hers were below our lower dotted line throughout the bulk of her pregnancy, and we sweated the whole time saying, gosh, is she going to hold on to this baby or not? We kept her on full hormonal treatment and the prednisolone throughout her pregnancy, and watched by ultrasound, and continued the treatment until 35 weeks, and 2 weeks after we stopped it, she went into labor and had a 5-pound, 5-ounce baby baby boy, and everything went well, and he did fantastically well. So that was great, and I said, after she had the baby, I was saying, gee, I'd love to put her on LDN the next time, because that baby is small, and he went a little bit early, and the hormones were actually quite low, and having discovered LDN since, I was dying for her to come back, and she did. So we said, let's try again, and I was very much thinking of this immune factor, and I said, in addition to our hormonal treatment, let's add naltrexone preconception. We did. She felt fantastically well on it. We continued the naltrexone throughout her pregnancy instead of prednisolone, and I would have anticipated that her progesterone levels would have been better, and she'd get a bigger baby, and that she'd just have an overall better pregnancy. And her hormone levels throughout were much, much higher. Compared to where they were before. They were really quite low for the first one, and that's where they were. And she had a 7-pound, 3-ounce baby girl who went full term courtesy of naltrexone. So with clinical experience, and what I was doing was I'd be thinking outside the box. I'd say, well, nobody's written this. Now, I'm a little unusual. I think Dr. Tom Gilhooly's unusual, and there's a few physicians who are prepared to think outside the box. For whatever reason, we're not as bothered by what our peers think, and we're going to go and do things that are a bit different because we've got a real clinical patient in front of us. There's nothing written about this, and the textbook hasn't been written for this, and the problem, we don't know how to solve it, and we're doing new things. And this has had a fantastic impact for us. And there's her baby girl. So the future for pre-treatment, my hope is rather than wait till somebody's had 6 recurrent miscarriages and all kinds of prolonged infertility and failed in vitro, is to get somebody early. And this is somebody who came, she'd horrific PMS, horrible fatigue, and a positive family history of a sister with polycystic ovaries who was coming to us, and the sister felt so well, she told her sister, you have to go on this treatment as well. And of course, very much what we use for this, for single women with these horrific symptoms, is naltrexone. So that was her chart, and we would red flag this straight away. Now this is somebody who never even tried getting pregnant. She wasn't yet sexually active and wasn't yet married and wasn't planning on conceiving, but her chart was screaming at us to say, we got a problem. So the real beauty of this is she could use it for reliable family planning, and when she's trying to get pregnant, we can treat the problems before she experiences them. And in the meantime, we can make her a lot more pleasant as well. So we found... most of the time. So her hormones were low, and clinically she had a lot of the markers for endorphin deficiency. We put her on natural progesterone endorphin stimulation with low-dose naltrexone, improved progesterone levels, her PMS was totally gone, her energy levels picked up, she was in great form, and it was fantastic. But her chart was still abnormal. So we had to go to the next level for her. So we did an ultrasound, and we found, in addition to her polycystic ovaries, she had an endometrial polyp, which we had surgically removed, and we had the combination of everything then. She was healthy and happy, normal chart, optimum hormones, went on honeymoon, and had a honeymoon baby. That's the ultrasound that we did when she was 8 weeks and 1 day. Baby is due any day now. I can't make it out from my scanner what the exact date is, but about this month. So for her, the problem was identified and solved before it officially existed, and the question is, what would have happened without LDN and NAPO technology? How long would she have experienced either infertility or miscarriage? And we don't know, but it's a tremendous advance in this whole area. For the future of LDN, it's essential that we correct vitamin D3 deficiency. I was hugely impressed, nearly done, with Dr. Tom Gilhooly's talk that I listened online at lowdosenaltrexone.org because of his work with vitamin D3 deficiency, because we're working on that as well, and we find it's really important for fertility. Food intolerance is a huge player as well that we're combining with hormonal treatment, naltrexone, and dealing with food intolerance. We do food print testing through cambridgenutritional.com, cambridge-nutrition.com, omega-3 treatment, and then progesterone treatment. These things are essential for LDN. I think it's really important, I'm just about done, just the closing point with naltrexone. The danger with, I think, the whole LDN movement is that we become LDN people and we don't want to look at the other stuff. I think it's so important for the sake of LDN, for LDN to achieve its full potential, you've got to correct for these other problems as well. You have to look at the other confounders. If there's a history of steroid use, in my clinical experience, I've seen those patients are more likely to have treatment failure with us with naltrexone, and I think there's something with that. I suspect it might increase candida, intestinal candida, and the naltrexone doesn't work for that reason. If there's current use of immunosuppressants, it's on the LDN website, the naltrexone doesn't work so well, and there's a trial that showed that as well. Hormonal contraceptives, to my mind, will also interfere with the effectiveness of naltrexone for some of the conditions, and you need a reliable compounding pharmacy. It's got to be the fast-release, lactose-free naltrexone, I think, to be the most effective. It's a disservice to patients if we ignore the additional factors that are more likely to make LDN work. And, I can't open that file. Oh, I had a letter that I was wanting to read from one of my patients, and of course, I might read it after you come back from coffee. It's just from the patient's own words themselves of what a patient had to say. She'd fibromyalgia, and she talked about how she got her life back as a result of it. And you talk about the lion with the sore paw, and you pull the thorn out of the lion's paw. It's that dramatic. We get so many people coming back, I can't believe it, I've got my life back. And the funniest thing is we're getting people with non-specific diagnosis. There is no established diagnosis, and they're just ill. They're clinically endorphin deficient. It really kicks in at the menopause time, because with menopause these things get accentuated, and if you have bad PMS, the menopause will kick you double hard, and that's where endorphin stimulation is a real lifesaver. So, and just to close on the note, I was reading on the LDN website before we came here that the presenters at this LDN conference, they look pretty lightweight to me. And okay, I admit I'm a bit of a lightweight. But from the patients that have spoken, you're the real heavyweights, and you got to run with this ball. And I saw somebody mention, the doctors have to talk to other doctors. Believe it or not, patients talking to the doctors have an even greater impact than fellow physicians speaking to them. So you're the one who has the condition, you're the one at the point of service, you're the one experiencing the benefit, and you're the one who can encourage more doctors to prescribe this for other people. So know the power of the impact you have as a patient who's benefiting to influence doctors to hopefully prescribe it for more